Bismillah ar-Rahman ar-Rahim. This is a presentation for arthritis. Bone has been discussed as bone tumors, bone dysplasia, bone density, bone infection, and now this is arthritis. It can be divided into hypertrophic, either due to bone production or due to sclerosis. Both are called hypertrophic. The second one is the infection, and in infection expect destruction of the articular cortex. The third type is the erosive, and this is characterized by marginal erosions. Hypertrophic arthritis is mainly degenerative, and in degenerative arthritis expect it could be primary or could be secondary. Trauma can be complicated by secondary degenerative arthritis, but in the same time we have the primary degenerative arthritis of the old females mainly. The second item in hypertrophic arthritis is the Charcot arthropathy, which is characterized by increased density and sclerosis, and that's why it is included here. Degenerative arthritis is mainly characterized by 5 X-ray findings. The joint space is narrowed. There is subchondral sclerosis. Expect marginal osteophyte formations, subchondral pseudocysts, and loose bodies, separate parts, separate fragments, which get calcified and called loose bodies. This is an example for degenerative arthritis, but as the appearance is usually diffuse, involving most of the distal interphalangeal joints, but even the proximal are also involved, so it is something diffuse. This is an example for the primary degenerative osteoarthritis. This runs in families. Now here, this is degenerative osteoarthritis, which can complicate either trauma, infection, avascular necrosis, calcium pyrophosphate deposition disease, or any inflammatory arthritis. In the knee, expect the changes at or along the weight-bearing surfaces, which is usually medial, while in the hip, expect it at the weight-bearing surface, which is usually the superior. So here it affects the superior. We can get narrowing of the joint, we can see the pseudocysts, we can see the marginal small osteophytes, and you can see the sclerosis of the opposing surfaces of bone. Here is secondary to fracture. There is narrowing of the joint, small pseudocyst formations, erosions, pseudocysts, sclerosis, and narrowing. Neuropathic osteoarthropathy findings are 3, D, and S. This is density change, sclerosis, destruction and fragmentation. These two results in disorganization, and usually there is soft tissue swelling around, very articular soft tissue swelling. So it is we can conclude it or abbreviate it like 3D and S. The causes for neuropathic osteoarthropathy: in the shoulders, usually syrinx or spinal tumors; in the foot, usually diabetic; and in the lower limbs, usually congenital indifference to pain. Congenital indifference to pain, this is something congenital. That means that there is no pathologic cause you can search for. This is a typical example of the 3D and S: sclerosis, density; disorganization, destruction; and deformity with periarticular soft tissue changes. Density, destruction, and disorganization or deformity plus soft tissue swelling. Sclerosis, destruction, and disorganization or deformity plus periarticular soft tissue swelling. If you remember these four, it will be nice. Now here again, sclerosis, destruction, deformity and disorganization, and periarticular soft tissue swelling. Periarticular soft tissue swelling. Here again, this is diabetic and this is diabetic. And if you look here, this is the calcified dorsalis pedis, and there is amputated toe. Here there is sclerosis, there is disorganization and deformity, and there is destruction of the parts of the bones forming joints, Charcot joints, or neuropathic osteoarthropathy. Four items to be remembered: 3D and S, density change, disorganization, and destruction, plus soft tissue swelling. Edema of the bone, sclerosis, periarticular soft tissue swelling, deformity due to destruction, and thus we can conclude, of course this is edema, we can conclude that this is neuropathic diabetic foot. Now another type of infection of arthritis. It's not hypertrophic degenerative or Charcot, but it is infective. Infective means destruction, and the best example is the destruction of the opposing parts of the bones forming a joint like this. Here the cause could be anything. The cause could be a wound, could be something iatrogenic following football sport injury, something like that, and the end result will be septic arthritis. Here we find massive destruction of the bony parts forming the joint and soft tissue swelling. The texture of the bone is normal here and there, so we can exclude diabetic foot. This one again is showing destruction of the bones around the joint. Fragments are seen anterior and posterior with periarticular soft tissue swelling. This is septic arthritis. Arthritis could be degenerative, could be Charcot, and both are called hypertrophic. Could be infective, like biogenic arthritis, and could be infective granulomatous. The best example is tuberculous arthritis, but fungus infection could be, and leprosy. So we have three granulomatous infectious diseases of joints: tuberculous arthritis, coccidioidomycosis arthritis, and leprosy, or tuberculosis, fungus, and leprosy. In TB, if it occurs in peripheral joints, expect the following. Any joint have a synovium, so expect synovitis, infection of the synovium, thickening, proliferation, tenosynovitis, swelling and edema of the tendon sheath, bursitis, any bursa could behave the same as a synovium, and erosions due to destruction, erosions and cystic changes, of course with formation of the caseous material, the abscesses. In all of these, TB characteristics in peripheral joints is mainly proliferation of synovium and cyst formations. Here we can find the pseudocyst formations around in the opposing surface of bone, subluxation, and synovial thickening around. Of course, the main feature of osteoporosis being chronic is osteoporosis. So expect osteoporosis, cystic changes or destructive changes, and synovial thickening. And once synovial thickening occurs with fluid inside the joint, any deformity you can get, subluxations are common. Here, this is a synovium, markedly full of fluid, markedly irregular and serrated and thickened, and this involves the whole thing. Avulsed part here, cystic changes or destruction. So we have bursitis, synovitis, and cystic changes with edema of the periarticular soft tissues, periarticular soft tissue edema. Now this is a tendon whose sheath is inflamed and thickened as T1 low, T2 high, tenosynovitis. This is an ankle showing minimal enhancing small abscess here with destruction of the bones nearby, tuberculous process. Talar dome cystic changes. So we are now getting the point that TB usually manifests itself near joints by cystic changes. Cystic changes of longer duration, of course, with periarticular soft tissue edema, and synovial thickening with fluid formation and reaction. In fungus arthritis, the process is not far from TB. Also, we have cystic changes, synovial proliferation, thickening, so we cannot differentiate granulomatous fungus or TB. In leprosy, expect that the leprosy can manifest in two forms, either neuropathic or erosive. Leprosy is infection, but can produce neuropathic appearances, and in this case you will find lost peripheral angual tufts or erosion of the angual tufts, or it could be erosive, as here, erosive with new bone formation around. So there is some destruction and there is some new bone formation, but the key point is that it's multiple and affecting more than one joint. Here the other type, in which the changes are mainly due to neuropathy. There is loss of the peripheral, or there is what we call acroosteolysis. Acroosteolysis. Erosive arthritis, this is the third category. We have finished now with the hypertrophic and with the infection. And in the hypertrophic we discussed the degenerative, whether primary or secondary, and we discussed the neuropathic. And the second item was the destructive or infective arthritis, whether pyogenic or septic arthritis, or the granulomatous arthritis, which is mainly manifested by cystic changes and proliferation of synovium, as in TB, or in leprosy we can get the two variants of leprosy, the neurotrophic type and the infective type. And in the neurotrophic type you will find lost terminal phalanges. This is called acroosteolysis. And in the infective type you can see the involvement of more than one joint with destruction, and in the same time, being chronic, there is some space for new bone formation. Now, erosive arthritis is a group which are mainly causing erosions. The key points are erosions. In rheumatoid arthritis, for example, the erosions affect both carpal and the carbometatarsal joints mainly, but the proximal interphalangeal joints are affected, thus resulting in deformities. In gout, there is big toe punched out erosion, this is the main. In hemophilia, being due to excess bleeding within the joint, there is hyperproliferation of the joint appears bigger or larger than expected, and there are some erosions along margins. In the rheumatoid variants, psoriatic or Reiter's or ankylosing spondylitis or inflammatory bowel disease, most of this can manifest in the sacroiliac joints. But we have other connective tissue diseases, systemic lupus erythematosus, sarcoid, and scleroderma. We will go through most of this. This is a typical example of rheumatoid joint. Rheumatoid joint, you will find the erosions, which we call it periarticular erosions, due to ingrowing pannus or ingrowing soft tissue inflammatory process. We can get synovial thickening, we can get subcutaneous nodules, and the cartilage will be eroded, some parts of it will be eroded, and there is periarticular soft tissue swelling. So we can conclude that in rheumatoid arthritis we have the pannus mainly, which erodes into the joint margins, especially at the capsular margins, capsular insertions. Number 2 is the synovial thickening. Number 3, the presence of articular surface erosions, skin nodules, and periarticular soft tissue swelling. To apply this here, carpal bones, for example, there are periarticular erosions, osteoporosis, of course, periarticular erosions, soft tissue swelling, and the same here, periarticular erosions. And in this one there is diffuse osteoporosis of the bones of the hand. MRI will show the typical periarticular erosions due to growing pannus and soft tissue swelling here and there, but you can detect also some erosions here. Bone edema can be seen clearly in MRI. Bone edema. Seen as T2 hyperintense. And tenosynovitis, like this one, like that one. These are tenosynovitis, means inflammatory reaction of the tendon sheath. So it is similar to that of TB, but of course the bone changes are different and characteristic, being affecting the metacarpal and metacarpophalangeal as well as the proximal interphalangeal. In rheumatoid, you can get the juxta-articular osteoporosis, compared to the bone density of the shafts of the bone, of the long bones, and here are some erosions. Although the foot is late to be affected, hands are more affected early, but you can see the juxta-articular osteoporosis. Here you can find the bone juxta-articular osteoporosis and erosions, soft tissue swelling around the proximal interphalangeal joints, fusiform soft tissue swellings, plus starting deformities. This is subluxation, and here another subluxation. So subluxation and soft tissue changes, beside the characteristic periarticular erosions and periarticular osteoporosis, are forming the main items for rheumatoid. Rheumatoid cause hyperemia, cause mobilization and bone softening. So pressure points like this, acetabulum is liable to have what we call protruso-acetabulum, and of course you can find that the joint space is markedly narrowed. And here the joint spaces are markedly narrowed. So early we can find early marked narrowing, and then in the hip you can get protruso-acetabulum. Late rheumatoid disease or advanced rheumatoid disease showing cystic changes periarticular, both the glenoid, the scapula, and the humerus, as well as the surfaces of both femur and tibia. Fracture scaphoid due to large erosions here and there. The key point is the erosions, this one and that one and the others here and there, and this result in a pathological fracture. Of course, the density of bone is decreased, periarticular osteoporosis and periarticular soft tissue swelling with erosions, as we said, are characteristics here and there and there, also affecting this area, and here is a fracture. Fracture olecranon due to large cystic changes of the olecranon and proximal ulna due to large cyst. Here are multiple subluxations and the deformities and the flexion deformities. It's nice to see the juxta-articular osteoporosis and the erosions, as well as the new bone formations around, with the deformities and soft tissue, periarticular soft tissue swelling. Here, marked narrowing of the joints, as we said early in the disease, starting marked narrowing, but here amounting to ankylosis. And here there are multiple joint narrowings, subluxations, and deformities, and all are mainly affecting the carbo-metacarpal joints, distal radioulnar joints, proximal interphalangeal joints here, and metacarpophalangeal joints here. Erosions are well seen, periarticular soft tissue, deformities and subluxation, and starting as joint narrowing. This is gout, in which the main the key point for gout is the tophi, the presence of tophi. Tophi could be juxta-articular, usually eccentric in one part, related to the capsular margins, or could be in the subcutaneous tissues. So we have tophi, which are because it is a deposition disease. Gout is a deposition disease resulting in erosion. Deposition of these tophi will result in erosions. Could be juxta-articular, could be within the soft tissue. We can have pathognomonic effusion of the olecranon bursa. It can be seen as stages, as acute monoarticular. Acute means with acute symptoms, pain and swelling and inflammatory reaction. Could be polyarticular, affecting more than one joint. And lastly, it rests as chronic tophaceous gout, or the chronic affecting more than one joint with multiple swellings with bone erosions. So the erosions are juxta-articular, near to the joint, related to the capsule again mainly, and eccentric in position, but it can be subcutaneous or soft tissue nodules. Typical appearances of gout affecting the foot, mainly the big toe, acute form with large soft tissue reaction, erosions, punched out, eccentric, near to the joint, and this is of course due to tophi. If we go in sequence, this is the acute form, and this is the polyarticular form, and this is the chronic tophaceous gout. Soft tissue swelling in the acute form with the erosions, soft tissue swelling with the juxta-articular erosions due to tophi. Periarticular calcification can occur because it is a deposition disease. These tophi may calcify after a while. These are the calcific tophi, calcific tophi, calcific tophi, polyarticular disease. Another deposition disease, which is due to absence of homogenetic acid oxidase, thus it forms excessive homogenetic acid, and this results in characteristic appearance of the calcific discs in the lumbar spine. This is called ochronosis. In hemophilia, we have narrowing of the joints, but larger joints than expected, osteoporosis due to hyperemia, and erosive changes due to the blood within the joint, erosive changes, and secondary reactive sclerosis. These are the main points. If you do a film for the knee and you find that intercondylar notch is wide, or there is some abnormal widening while the joint is narrowed like that, this is characteristic of hemophilia. Wide intercondylar notch. This disease is not hemophilia. Of course, this is what we call systemic lupus. In systemic lupus, we can get the cup and pencil deformity or resorption of the terminal phalanges and the multiple subluxations. Sorry, this is psoriasis. So in psoriasis, you can get the lost phalanges and the narrowing joints with subluxations, and here the cup and pencil deformity. In psoriasis, sometimes you can get unilateral sacroiliitis or spur formation. In scleroderma, you can get acroosteolysis or soft tissue calcification. Acroosteolysis, so the leprosy can produce acroosteolysis. Scleroderma can produce acroosteolysis, and we can get soft tissue calcifications in scleroderma. The name implies that the dermis is sclerosed. That means soft tissue calcifications. So again, we can go through this group. Ochronosis is another deposition disease seen as calcification within disc spaces. Hemophilia is characterized mainly by the osteoporosis around the intercondylar region with wide intercondylar fossa and minimal sclerosis around. The joint appears bigger and osteoporotic with appearance of the coarse trabeculae and disappearance of the fine one. Hemophilia. And this, as we said, psoriasis, and in psoriasis you can get again acroosteolysis, so or pencil in cup and pencil appearance. So we have acroosteolysis in leprosy, acroosteolysis in psoriasis, and acroosteolysis in scleroderma. Now we have three. Acroosteolysis means absorption of the terminal phalanges, occurring in leprosy, in neuropathic type, and in psoriasis and in scleroderma. In lupus, the main or the key point is subluxation. The key point for lupus joint is subluxation. In lupus, you will find effusion and subluxation. You see here the bad alignment of the joint, while the joint is swollen, full of fluid, and this results in this subluxation. Sometimes, because lupus is vasculitis, it can result in avascular necrosis. One of the causes of avascular necrosis of the femoral head being vasculitis. Systemic lupus. Now, sarcoidosis is a granuloma, similar to TB, similar to fungus. So expect cystic changes. Cystic changes like cystic TB and cystic fungus infection will result in such an appearance. This is bone sarcoid. There is enlargement of the nutrient foramina, but this is not characteristic. Coarse trabeculation, large, well-defined lucencies, resorption of the distal phalanges, and this is the fourth one in the acroosteolysis. To repeat again, it is leprosy, psoriasis, sarcoid, and scleroderma. Leprosy, psoriasis, scleroderma, and sarcoid. All of these result in resorption of the distal phalanges. Periarticular calcification can occur, but as we said, the main key point for sarcoid are the multiple cystic changes. In ankylosing spondylitis, you will find narrowing early, widening of the joint, then narrowing of the joint. Of course, the joint margins will be edematous, as in MRI appearance here, and there is overlap and trial to narrow the joint. In ankylosing spondylitis, you will find edema of the opposing end plates, so it is discovertebral lesion, and we can get the calcified anterior spinal ligaments. And this edema, remember, this early edema of the corners of vertebrae could be due to ankylosing spondylitis. We can see such an appearance frequently, but nobody is aware of that. It can be due to focal edema of the anterior discovertebral. So edema of the anterior, focal edema of the anterior part of the discovertebral junction or region is part of the disease in ankylosing spondylitis. Again, we can repeat ankylosing spondylitis in sacroiliac joints. Start as widening, then edema, then narrowing, then ankylosis. And in the vertebrae, it can be discovertebral lesions in the plates, or anterior focal edema like this, or the famous calcific anterior spinal ligament and posterior spinal ligament, as well as calcification of the annulus. So another cause for calcification of the annulus, we have ochronosis, and the second is ankylosing spondylitis. So here we get the disc calcification, like that. And if you imagine faintly, there is something inside here and there. Disc calcification, as well as calcification of the anterior spinal ligament. Costovertebral arthropathy is again part of the ankylosing spondylitis. Costovertebral arthropathy, and here the calcified ligamenta flava. In this one, you will find atlantoaxial fusion or erosion of the dens. Erosion of the dens could be seen in rheumatoid, could be seen also in ankylosing spondylitis. So you can have atlantoaxial fusion as here, or erosion of the dens at this one, and this is a differential with rheumatoid. Posterior spinal calcific ligament with fracture spine, calcifications of the posterior spine ligament, fracture vertebra, all can be seen in ankylosing spondylitis. Here the typical bamboo spine of ankylosing spondylitis. So as we said, calcification can be in the annulus, can be in the surfaces, can be in the anterior spinal, could be in the posterior spinal, could be in the ligamenta flava, and so on. This is typical calcification posteriorly and typical dense destruction, typical bamboo. And the differential diagnosis is the hyperostosis, ankylosing hyperostosis of the spine, or we call it dish, the diffuse ankylosing hyperostosis. Now this is again acroosteolysis. What are the causes of acroosteolysis we know about? We have leprosy, we have psoriasis, we have the sarcoid, leprosy, psoriasis, sarcoid, and can go back to see what is missed. Psoriasis, scleroderma, sarcoid, and leprosy, and finally there is one here, what this could be. This what we call thermal injury or frostbite. Thermal injury or frostbite. The tips of fingers are lost. Intra-articular masses can be classified as non-infectious proliferation of the synovium, infectious granulomatous disease as TB and fungus, or deposition disease. These are the main three. Vascular malformation is rather another possibility, but rare. Now, non-infectious synovial proliferation processes like lipoma arborescens. This is non-infectious proliferation, and like synovial osteochondromatosis, and like pigmented velonodular synovitis, and lastly the panas of rheumatoid arthritis. So again, this is the intra-articular masses can be classified into non-infectious synovial proliferative processes, infectious granulomatous disease like TB and fungus, deposition, vascular malformation, and other rare conditions. The main non-infectious synovial proliferative diseases are the lipoma arborescens, synovial osteochondromatosis, pigmented velonodular synovitis, and rheumatoid arthritis. And this is a typical example of the lipoma arborescens: fatty projections coming into the synovial space with effusion, frond, you call it frond, and this is the synovial osteochondromatosis, another example of the pigmented velonodular synovitis, as seen as lobular, villous, and nodular projections loaded with hemosiderin, so seen in the MRI as low densities. And in the plain film, we were diagnosing this before the invention of with the use of MRI as cystic changes on the opposing surfaces of the big joints. Cystic changes on the opposing surfaces of the big joints with some reaction around and soft tissue swelling. We're diagnosing pigmented velonodular synovitis this way. It's formed, as we said, from lobular, villous, or nodular projections with hemosiderin deposition, thus resulting in low intensity in the MRI, as seen here. Multiple nodules, villous projections, and nodular projections from the synovium. These are causes of non-infectious proliferative synovial diseases. Deposition, of course, we know about gout, and then the other type is the calcium pyrophosphate deposition disease, which could be idiopathic or a part of hyperpara or hemochromatosis. This is the calcification within the joint. Vascular malformation is typical in clipal terinary syndrome, or what we call the giant limb due to abnormal vessels, due to abnormal veins and arteries. Photographs showing nevus flammeus. Nevus flammeus means that the skin discoloration due to the vascular proliferation, and it results in a giant limb, as you see. The main cause for giant limb in teenager is the clipal terinary syndrome, provided that you can see a nevus on the skin. Malignancies including synovial chondrosarcoma, and synovial sarcoma, and synovial metastasis, but the famous is the synovial sarcoma, which is seen related to the synovium, usually outside the joint, not inside the joint. A soft tissue mass near but not in a joint in a middle-aged patient, particularly with calcification, is very suggestive. So again, synovial sarcoma is a soft tissue mass near but not in a joint in a middle-aged patient with calcification, is very suggestive. Thank you.